All right, so welcome back to Emergency Medicine Part 2. I did the first part of this months ago in the summer semester. Now I am almost done my first rotation of my second year of PA school, which happens to be emergency medicine. So well, we left off with Toxicology 1. We're going to pick up on Toxicology 2, talking about the alcohols here, go into some environmental stuff, and then some fast track. So hopefully we will hit some high yield stuff and pick up some points on this EOR exam. All right, so straight into it. The second part of toxicology here is going to be about all of the alcohols. So we have methanol, ethanol, ethylene glycol, and isopropyl alcohol. You can see the chemical structures here. The important thing here is that all of these, and an alcohol is defined by a hydroxyl group, which is this OH group, which you can see on all of these. All of these will create an osmolar gap or osmolar gap, but the only two that are going to create in an anion gap are going to be methanol and ethylene glycol. So not ethanol, which is just normal alcohol, ethylene glycol. And that's going to be your M and your E of mud piles, which is metabolic acidosis with an anion gap. So we'll start here with methanol. The toxic product here is going to be formic acid. Not sure how important that is, but you're going to see this in things like sterno, paint thinner, windshield washer fluid, and then, of course, wood alcohol, which is moonshine. I think the big thing here is irreversible blindness. So if you see a patient come in, they took something and they're blind. So that's going to be the big one here for methanol in terms of buzzwords. And then just know the treatment is fomepizole. So that's going to be the treatment both for methanol and ethylene glycol because it's a competitive inhibitor of alcohol dehydrogenase, or you can actually give somebody IV ethanol. That's going to be, it's like the lesser of two evils here. You'd rather give them that. You want it to eat up all the alcohol dehydrogenase so that your body can stop breaking down methanol into the toxic formic acid. Okay. We'll actually go down here. So we'll go to ethylene glycol. So sort of similar-ish, but you're going to find this in things like automotive coolant and antifreeze. Again, you have that anion gap, metabolic acidosis. This one here tastes really sweet. So children and pets are going to be more likely to intake this. Some buzzwords here are going to be the calcium oxalate crystals that you'll get on urine microscopy. And then it's going to glow in the dark. It'll actually glow blue. You can see the picture down here. Yeah, fluoresce under ultraviolet or Wood's lamp. Toxic product here is going to be glycolic acid. So ethylene glycol, glycolic acid makes sense. So that's the big thing, calcium oxalate crystals. It's going to cause an AKI. Some other stuff here, but fomepizole is going to be the go-to. All right. Ethanol here, just know that there's a 20 milligram per deciliter reduction every 1 hour. You want to get them down to the legal limit, which is 0.08 or 80 milligrams per deciliter before they're safe to be discharged, or if there's somebody that is willing to take care of them and take them home. This is the only one of the four that you can actually take a blood level for. So we know that, but it's interesting to know that the other three you can't. Isopropyl alcohols, like rubbing alcohol, hand sanitizer. You can see a fruity odor to the breath, which is pretty interesting. And then I think the big buzzword here is that you can get hemorrhagic gastritis. So that's good to know. And treatment's just going to be supportive. Because of that, you can consider H2 blockers or PPIs. All right, not too bad. CO poisoning, the big thing here is this 90 minutes. So that's usually always tested on 90 minutes on 100% O2 is going to be the half-life. Hyperbaric chamber, not really relevant. Room air, maybe not really relevant. There could be a question of like, they were at home for 2 hours or something, or they were, like outside, but whatever. 90 minutes is going to be the thing you want to know. All right, caustic injections. And then, yeah, like for CO, look for that in house fires. And then you're also going to see cyanide comes up somewhere in here as well. So know that if they're not suffering from CO poisoning, they could be suffering from cyanide poisoning. So definitely catch that or take that level. All right, caustic injections. The big thing here, or caustic ingestions, the big thing here is that acids, so AC of acid, causes coagulation necrosis. So the C in coagulation, most severe in the stomach. And then liquefaction necrosis, which is just going to turn your tissues into liquid, which is crazy. That's going to be worse. So that's going to be in the alkali. So alkali, the second letter is L. So L for liquefaction and C for coagulation. Okay. You're going to see alkali in things like liquid drain cleaner, and then you're going to see acids in like toilet bowl cleaners. All right, moving on to digitalis. So this is a big one, a lot of buzzwords and things here. Know that you can get hyperkalemia because it's going to inhibit the sodium potassium pump. So potassium is going to leak into the extracellular space. And the big thing here is that it can cause almost every single arrhythmia under the sun. The number one is going to be PVCs. However, the one that is pathognomonic for this is paroxysmal atrial tachycardia, PAT. So PAT, digitalis toxicity, that's a big one. Your patient might be complaining of yellow-green distortions, yellow halos around lights, and then very easy, you just want to give them Digibind. All right, hydrocarbons. This is gasoline, turpentine. The big thing here is like with aspiration pneumonia, you're going to get a VQ mismatch. You can get dysrhythmias here as well. Just supportive therapy, I think, is the big one. And oh, permethrin. That's like the scabies and lice treatment. That's interesting. All right, iron. Look for a child overdosing on vitamins. The interesting thing here is you have a disruption of oxidative phosphorylation. So you are going to get an anion gap metabolic acidosis. So this is one of the eyes in the eye of mud piles. The big thing here is you get hyperglycemia. So this could, potentially present like a DKA, especially because you can get all these GI symptoms like vomiting and diarrhea. So look for that on a vignette. You can also get lactic acidosis. So you're kind of getting a double kill here for the acidosis. That's interesting. And then you want to know the treatment here is deferoxamine. So deferoxamine, the FER is kind of in there for iron. So you're de-ironing from oxygen. I mean, there you go. So de-iron, so DFE from oxygen, sure, from your body. And then you can get this Vin-Rose urine. That's going to be the presence of the chelate, which means that it's working. So if you see this wine colored urine, that means it's working, and then it's going to go back to normal color, which means you're done. So you can think of iron and wine, which is a band. All right, lead poisoning here, lead paint, you're going to get anemia. You can get formation of lead lines on an X-ray, which is interesting. Just run labs. I think just know the treatment for this is dimer, caprol, and editate. And I have this little mnemonic here. So Teddy Roosevelt is on the dime. So you want to call him Letty Roosevelt, like maybe the dime is made out of lead. So that's where you make that connection between dimer, caprol, and lead poisoning. And then editate is leaditate. So those are the two with lead poisoning. So that should get you the answer there. Here's the X-ray finding, those lead lines. Yeah, that's very interesting. Look at that right along the growth plate there. Cool. Could totally come up in a picture. Sulfonylureas like glyburide, glipizide, glimepiride. Treatment here is just D50. So these are like insulin, secretogs or secreted togs, whatever. I have a lot of trouble with words, apparently. But yeah, D50 is going to be the treatment here, or you can do glucagon, and they're probably going to be there for a while. You're going to have to do continuous IV therapy, I guess, while the half-life of this runs out. So definitely good to know. All right, we're going to go right into environmental. A lot of interesting stuff here. So you definitely want to know your total body surface area for burns. Once 30% total body surface area, that's when you want to Oh, that's when you get this like cytokine triad. So that's when you know it's bad, right? More than 30, I mean, it's always bad if it's like full thickness, but greater than 30%, you really want to be concerned. Anything greater than 15%, you're going to use that Parkland formula for your fluid, which we'll talk about in a second. I don't think the path is very important here. Um, Stock and glove scalds are always something you want to look for to suspect child abuse. And then the rule of nines is going to be important. So for an adult, it's just 18 front, 18 back, and then 18 each per leg. Everything else is nine. So your arms and your head. For kids, they have large heads. So you're going to double the size. So you're going to double that to 18. And then they have smaller legs. So you're just going to take four away from each leg. You're basically taking away from the leg to add to the head. So just know that their heads are 18, arms are the same, front and back are the same. But knowing those legs at 14 is going to be important. And then a patient's palm, not your palm to the patient, but the patient's palm relative to themselves, that's going to be 1%. Okay. So the big thing here, we don't use like secondary burns, tertiary burns, or whatever, primary, second, how, whatever. You used superficial partial thickness, deep partial, full thickness. Oh, third degree, first degree. Those are the words I'm looking for. The big thing you want to know here is full thickness, which were previously third degree, is when the affected area is painless. So if the patient cannot feel, this is going to be full thickness. My mnemonic here is full fat and feel nothing because it's full thickness. It's into the fatty tissue, and the affected area is anesthetic or painless. Okay. All the other ones, I really don't think are that important. Knowing full thickness and third degree and that you should be able to go one below or one above if the question is something different. What is interesting though is that superficial burns like sunburn, as bad as this looks, is not considered when you're doing a total body surface area um, calculation. So you probably give them fluids anyway, but you don't need to put this into like a Parkland formula or anything like that. All right. So moving on to more burns here. So yeah, greater than 15% is going to require IV fluids. The Parkland formula, so it's just 4 milliliters per kilogram, and then times the percent total body surface area. Once you get this, you need to give this fluid back to them. Maintenance fluid is going to be additional. You're going to take this fluid, you're going to give them, I think, the first half in the first 8 hours. Yes. And then the second half over the following 16 hours. So you kind of load them up first, you give them that first half, and then you give them the second half over twice as long. All right. You bring that down to 1 milliliter per kilogram per hour in pediatric patients. I guess there's not a total body surface area involved for the peds, but this is usually the big one, is 4 ml. Know that silver sulfadiazine or Silvadene is a topical antibiotic of choice, and you want to avoid this in sulfa allergies. It's in the name, so that's pretty easy, but that is important to know. And then do tetanus prophylaxis. Okay, and then just pain management and stuff. Moving on to electrical inner injuries. So I think what's important here is, milliamps is the primary determinant. Wet skin lowers resistance. I think knowing that direct current injury causes a single muscle contraction that throws a victim. So it directly throws you across the room, or think of DC's, like DC Comics, Batman throwing people. So a direct hit to throw you across the room is pretty easy to remember. The head is a common point of entry for high voltage injuries. So look for head, ears, nose, and throat injuries, things like hyphema, retinal detachments. That's pretty interesting. If a child chews on an electrical cord, the most likely, or at least most concerning anatomical area for that is going to be the labial artery. So look out for damage there. Oh, I hope this is recording my voice. Stop recording. Yeah. Okay. Testing. All right. So I think that's it. AC is going to be usually more dangerous because it's going to prevent you from letting go. Yeah, at just greater than 10 milliamps may result in inability to let go. And I think AC, because it just keeps going through your body and going through your body, that's the one you want to watch out for. All right, moving on to prickly heat. Whatever. It's also called miliaria or heat rash. Look for intense sweating. The path here is just a blockage of sweat ducts and then topical steroids or mupirocin, which is used for impetigo, right? Yeah. Yeah. Moving on to heat cramps. Heat is not a requirement for cramping. Like you can get this in the cold. You don't have to be at the, Winter Olympics, you can get heat cramps because it's the heat of your body. So you want to replace hydration and sodium because you're sweating so much, right? Heat exhaustion. So the big difference between heat exhaustion and heat stroke is that the central nervous system is not affected. 101 to 104 is our threshold here for heat exhaustion. Once we get over 41 Celsius, so 105 Fahrenheit or 105.8 is when we get into heat stroke territory. We want to cool the patient. Best way to always rehydrate somebody is orally. So PO. Heat stroke, so again, 41 or 105, that is what's going to put you into this altered sensorium or CNS dysfunction. Evaporation is a primary means for athletes exercising in hot environments in terms of mechanism for heat loss. All right, so evaporation, but a good one to know is that conduction is direct heat transfer. So that's like putting an ice pack on yourself or jumping in water. Don't get that confused with convection, which also has to do with a liquid, but that's like pouring water on yourself. Will you get some conduction with that as the water comes in contact with you? Yes, but it's running over your skin. So that is going to be convection, a gas or liquid moving over the body. And that includes wind. So fanning yourself is going to be convection. All right. Radiation is just the natural heat loss to the environment, like going into the shade. But knowing that, conduction is direct contact, like jumping in water or, holding ice or putting yourself, putting an ice pack on is good to know. Yeah, I think potentially you want to know risk factors for this. So if you have somebody on, a diuretic, they're losing fluid, or beta blocker, calcium channel blocker, something that's reducing the blood flow to the skin. So these antihypertensives, look for that. All this other stuff too. More about heat stroke. So a lot of stuff you want to treat slowly, like hypertension, for example. But this you can totally cool them rapidly. So you want to get them to 39. God, I hate Celsius. So we were at greater than 41. At least that's the risk with the altered sensorium. We want to get them down to 39. And this is always good to know. You can use benzos like Ativan for agitation and shivering as you are cooling them down. All right, moving on to the cold here. So this nice solid 3595 is a great number to know for hypothermia. Okay. So less than 35 or 95 Fahrenheit. There's three categories here. So 35 to 32, you're good to use external rewarming like a bear hugger, a warm blanket, groin bottles, things like that, warm water. And then if you go on the opposite side of the spectrum, less than 28 is where you can you could become pulseless. So that's not good. So no, 35 and 28 are good Celsius numbers to know in terms of hypothermia. And then 101 to 104 for like heat exhaustion, should get you where you need to go. What else is good here? Cold-induced diuresis, paradoxical undressing. Yeah, Osborne J waves. I've seen them twice come up in all of this. That's in hypothermia and then in hypercalcemia. So a good buzzword to know here. External rewarming can cause this paradoxical core after drop. The body tries to fix our efforts with peripheral vasodilation, which drops the temperature even further. So watch out for that. Whatever, blah, blah, blah. Know that this affects the heart. I think that's definitely good to know as well. There's decreased depolarization of cardiac pacemaker cells. All right. Frostbite. So if you treat somebody for frostbite by immersing them in circulating water, necrotic tissue of like where on their skin died takes weeks to months. So you won't know, like, you'll treat them, you'll get their foot or whatever warm, but you won't actually know what died for weeks to months. So that's really important. Don't stop rewarming due to pain. They need to fight through it. So it's going to hurt as you're putting the circulating water. But you want to just give them some pain meds because you don't want the necrosis to spread. But yeah, weeks to months to establish non-viable tissue to consider amputation. That's really interesting. I wonder what the path is for that. Trench foot, look for this, and this is what, like, wet, non-freezing, cold temperatures. This is Band of Brothers, one of my favorite shows of all time. Yeah, I should watch that again. Okay. So then there's kind of like three levels of altitude here for altitude sickness. There's acute mountain sickness, and then there's HAPE, which is high altitude pulmonary edema, and then you have high altitude cerebral edema. This is okay. So acute mountain sickness, the big thing here is that a patient can present like almost that like they're hung over, and you could potentially misdiagnose them here. Oh yeah, I have it here. Maybe misdiagnosed as a hangover. The big thing for all of these is rapid descent. That's always the answer for, like, how to treat this. Just stop climbing a mountain. You need to get down from where you are. Okay. A patient might come in with like, oh, I have these headaches. I'm having difficulty sleeping. Ask some questions. Hey, were you just hiking up a mountain? Okay, not good. One of the really interesting things here is so Diamox. So not only is this a treatment, you can take this as like an altitude pill. And I think this is fascinating. It's an alkaline diuretic. So it's going to take out all of the bicarb from your serum, from your fluid. It's going to put you on purpose into metabolic acidosis, which will trigger your lungs to hyperventilate to blow off that acid. But in doing that, the hyperventilation increases your oxygenation. I think that's a really cool mechanism for a medicine. So that's what acetazolamide does. And then you can use just dexamethasone for headaches. So yeah, you have this hyperventilation. And yeah, hyperventilation will then lead you to, as it's correcting the acidosis, will lead you to a respiratory alkalosis because you're blowing off all that CO2. So nice little combination there. Okay, then you can go up to high altitude pulmonary edema. So this is non-cardiogenic pulmonary edema. So like kind of like ARDS, right? You could see frothy sputum, and you'll see this on a chest X-ray. Again, you can use Diamox and then descent. And then kind of the worst here is high altitude cerebral edema. And this usually occurs with people who are not feeling well and they keep going up. So again, you'll see these issues with sleep and then severe loss of consciousness during sleep, which I thought was interesting because, like, aren't we all unconscious while we're asleep? Like, I don't really know what that means. consciousness during sleep. Like you don't dream. Like, is it you like stop breathing? Okay, that makes sense. Like you go apneic, but like I don't know. I thought that was really interesting. I guess you would have to see that on like an EEG or something. Or like you're asleep and you just like you don't respond. I don't know. Whatever. Immediate descent, or you can use these. What are those bags? There's like a I forget the name of it. Oh, a Gamow bag. It's like a portable hyperbaric chamber that you can bring up. That's crazy. How does that work? Wild. Okay. Moving on to diving illnesses. The big thing here from a path perspective is know that there's nitrogen accumulation in the lipid components of your tissues. And you could see middle ear barotrauma and tinnitus. So make sure you do an ear exam here. Yeah, you have these nitrogen bubbles which enter the vasculature. So just know that for diving illnesses. If I can't scuba, then what's this all been about? Oh, this is Diamox. All right, decompression sickness. Also, so there's three types. The first one, type 1 mild, is the bends. Know that you can't fly after diving. So apparently when you go scuba diving, they ask for your plane tickets to see, well, when are you flying? So if you do even a less than 2 hour dive, you have to wait 12 hours to fly home. You just want to treat with oxygenation and hyperbaric oxygen. Improvement with hyperbaric oxygen is diagnostic, and you can get gas emboli. So don't rapidly ascend. You can use vinegar for jellyfish stings or baking soda, which is pretty interesting because vinegar is like acetic acid, right? It's like acidic and baking soda is basic. So just disrupt the pH of the sting. I don't know. All right. We're almost done actually. So this is just kind of like a hodgepodge miscellaneous PowerPoint of like just pearls basically. So we'll kind of talk through this. Everyone with a headache does not need a CT scan, especially kids. You don't want to overdose them with radiation really for no reason. Look for, what is this? Malignant otitis externa, yowza, acute mastoiditis. Okay. Diabetes was always a big risk. This is from endocrinology. So diabetes is an increased risk for malignant otitis externa. So an external ear infection for DM. You will see that. Mastoiditis, blah blah blah. Stuff about sore throat, epiglottitis, thumb sign. You have your abscesses, retropharyngeal abscess, which usually comes from like you were sick before and it spreads. And then Amstelbactum is it's unison, right? Not Zosyn. Zosyn is yeah, that's piperacillin. So this is unison. Because I remember piping hot Tazo tea. All right, then we get into, look for chemosis and cobblestoning for allergic conjunctivitis. Salter-Harris fractures, it actually took me 2 semesters to realize that this is only in kids because it has to do with the growth plate. So stupid of me, but that's a crazy thing with PA school. You see things so many times, and if you just don't have the time to take 10 seconds and really think about what am I even learning? There's so much happening. You're just memorizing things, and you're like, what even is this? So these are different ways that a, a pediatric fracture can present when the fracture has to do with the growth plate. So this is just normal. Straight across, which is like impossible to see. There's a fracture like right here, hard to see. A looks like an A. So if you look at this, like if you take the letter A and literally put it on its side, that's a type 2. So and I forget all the names of the anatomy, metaphysis, epiphysis, whatever. Oh, we'll get to that in a second. So that's the A. L includes the hard part of the type 1, the type 3, this one here, but you'll see it go through here. 2 is really easy to see on an X-ray. 4 is really easy to see on an X-ray. So you could split the difference. 5 looks very similar to like the normal one because it's just like a crush injury. So if you know 4 and you know 2, you'll be completely fine. Here's just another way to look at this. So here's the A, the little tip of the A here for type 2. Here's all the way through for type 4. So the metaphysis. So just kind of, yeah, kind of another way to look at that A. So again, you have the A here and then 4 done. I don't know if I actually have. So here's actual X-ray. So this is a great one. This is a 2. So this is the corner of your A, right? I I can never see this picture for 3. I have no idea. But 4, very easy again. So there you go. This one you could see, you don't have a lot of space there. So that should get you through. Just remember, 1 is this, like very hard to see. So if you see the little A, that's 2, and then just go from there. And it goes up to 5. Clavicle injuries and upper extremity injury, anterior shoulder dislocation. So this is that Y sign. If the head of the humerus is to the right in front of it, it's an anterior dislocation. If it's behind, it's posterior. So look for like seizures or electric shocks. Yeah, there you go. Supracondylar humeral fracture. So they'll present with this median nerve, but the actual branch of that is the anterior interosseous nerve. But know that that's doing this okay sign. If you can't do this and you can only do this, that's a median nerve injury. But it's supracondylar. So the issue is all the way up here on your humerus, but it's, that the median nerve goes through there. So that's why there's an issue there. And then know that the brachial artery, so brachial artery, median nerve are all in that area for supracondylar. Very important. Fat pads, a little bit of an anterior is normal. Okay, so this is normal. A bigger one here, not good. Posterior, not good. So there's a radial head fracture here that is causing that. And yeah, you can, your AC, it's kind of meaty. It's not, it's just the way I remember it. But if you like feel your ulcranon, you feel your elbow, that's pretty hard. So fat pad normal, fat pad not normal. Yeah, whatever. There's all this stuff. Whatever. All this scaphoid, anatomical snuff box. Know that the radial nerve is like back here, median nerve, median nerve, the distribution of that. Old ulnar nerve, the distribution of that. Gamekeeper's thumb is about that UCL because UCLA has sports teams that play games. Mouth finger is going to be that avulsion of the extender tendon. So if you have an avulsion of the extensor tendon, obviously you can't extend. So when you splint them, and I think this is like 6 months or something crazy, it has to be in full extension because you need that tendon to be joined. And if you just do that for a little bit, it's going to rip apart again. So you have to splint them in full extension. Number 1 infection in the hand is paronychia. Look for herpetic Whitlow. MRI of the hip to look for what, like avascular necrosis and stuff. Yeah, elderly patients with hip, groin, or buttocks pain. Ottawa knee rules, taking the L on that. It's criteria nobody ever uses. I will happily miss the question on that because I just don't care, honestly. It's just not worth the time. Yeah, whatever. Inability to bear weight for 4 steps. Get an X-ray. You're going to get an X-ray anyway. It's not that much radiation. Tibial plateau, most common knee fracture. That is important. And then like open fractures are going to be common in the tibia as well. Normal Bowler's angle is what, 20 to 40. And like less than that, right? If you decrease the angle, yeah, you'd slip off and fracture. Oh no, decreased is not good. whatever, just know Bowler's angle, calcaneus. Yeah, so this is the Lisfranc fracture, and this again is something I've always looked at this area of the X-ray and been like, that's Lisfranc, whatever. I never noticed that the metatarsals are all shifted to the left. Look at this. It's you take these four metatarsals and you literally shove them all laterally here. I never noticed that. It's crazy. This isn't the greatest thing to look at. This is oh that's Lisfranc. And it's this, yeah, it's the base of the second metatarsal is where this is all happening. So the medial cuneiform with the base of the second metatarsal gets messed up, and all four of these get shifted to the left. Crazy. This one, I guess, is more subtle, but this, I mean, that's very, very clear. The fifth toe is the most commonly fractured. Apophysis, this is always a good thing to know. This looks like a fracture, but it's not. Fracture is going to be transverse, like this picture. Oh, this is it actually. UTIs, I can never remember this. So uncomplicated, female, healthy, 15 to 45. So if they're a childbearing female, it's an uncomplicated UTI. If she's young or if she's, older is obvious to remember, but 15 to 45, remember that, not pregnant. And then remember symptoms greater than, less than 7 days. They always like to ask questions of like, it's been 9 days. Is this complicated? Is this not complicated? So that's it. That actually didn't take nearly as long as they thought. That is emergency medicine part 2. And I will see you in the next one.